A very good evening. I will take the privilege to gather this August gathering of our today's scientific program on sexual dysfunction. So, without wasting further time, let's introduce today's subject. So, what is actual sexual health? We all are very known about WHO health definition, and likewise, the sexual health can also be defined as a state of physical, mental, and social well-being, and not merely the absence of disease in all matters relating to the reproductive system, its function, and its processes. So, next comes in our mind, what is sexual dysfunction? Sexual dysfunction is any problem that interferes with a person or a couple sexual satisfaction. And how common? How common are sexual problems? As per Cleveland Clinic data, up to 43% of women and up to 31% of men can experience sexual dysfunction in their lifetime. So, despite this high percentage of data, people generally don't talk much about it, and they usually consider it as a taboo and suppresses the fact. So, our prime objective to some extent will be that to share the knowledge about the sexual dysfunction among the different groups of populations, and so that they don't suppress their this dysfunction as a taboo and expresses their concern to the doctor, urologist, or gynecologist whatsoever. And this sexual dysfunction actually can hamper all the 4 phases of sexual response cycle, starting from the arousal up to orgasm or resolution. To evaluate the sexual problem, a 3-dimensional model sometimes has been developed, depending on the fact that like duration it may be primary or secondary, depending on the context it might be global or situational, and depending on the frequency it might be partial or total. Next comes, what are the types of sexual dysfunction? Basically, sexual dysfunction are categorized in 4 types: desire disorder, arousal disorder, hormonal ailments, diabetes mellitus, chronic kidney disease, liver failure, vascular and cardiac causes, use of alcohol and other related substances. In addition, there are certain other drugs like serotonin, etc., inhibitors and other antidepressant drugs which may also contribute to sexual dysfunction. Among the psychological causes, mainly the fear, anxiety, guilt, stress, these all contribute to sexual dysfunction. Fear of pregnancy, infertility, abuse, partner violence, anxiety about relationship issues, money, ability to respond, ability to please partner, lack of sexual experience or knowledge, these all contribute. Guilt over lack of feeling for partner, unfaithfulness, masturbation guilt, sexual fantasies, past behavior, betrayal of partner, lying, cheating, and stress due to job or work, money, family problems, family illness, loss or grief, children and child rearing, these all contribute to sexual dysfunction. And also the relationship issues is very much important for sexual dysfunction. Loss of trust, poor communications between partner, anger and resentment, conflicting sexual expectations, lack of respect, loss of love. This whole constitutes a complex, and any problem in any of these 6 points can produce sexual dysfunction. Now coming towards the male sexual dysfunction, as I have already told previously, pain disorder is less common in male. Only 3% of the male experiences pain during penetration. So mainly 3 contributing factors for male sexual dysfunction. One is diminished libido, second one is erectile dysfunction, and third is ejaculatory disorder. Disorder of desire are due to psychological causes like anxiety, depression, anger, fear, attitudes, memories, and certain psychological conditions like depression, obsessive compulsive disorder may lead to sexual dysfunction. Other psychological causes, attitude, fear, psychological disorder that contribute to sexual disorder occurs within a social context like divorce, death, job stress, infertility, and or relationship difficulties. This contributes to sexual dysfunction. Cultural standards can set the stage for development of these disorders also. The trauma of sexual molestation or assault is especially likely to produce disorder or sexual disorder, more common in female. Now coming to the erectile dysfunction. The risk factors involve cardiovascular diseases, diabetes mellitus, chronic kidney disease, hypertension, obesity, smoking, dyslipidemia, obstructive sleep apnea. Among the psychological causes, depression, stress, relationship issues, neurological causes, stroke, spinal cord or back injury, multiple sclerosis, dementia, and there is a whole lot of drugs that can produce erectile dysfunction, starting from antidepressants, selective serotonin reuptake inhibitor, and to some extent the anti-hypertensive medications like thiazide diuretics, angiotensin receptor blocker, ACE inhibitors, anti-androgens, all can contribute to erectile dysfunction. Other medications like spironolactone, sympathetic blocker, ketoconazole, cimetidine, that can produce erectile dysfunction. Among the endocrine disorders, hypogonadism is the most common factor, then hyperprolactinemia, hyperthyroidism or hypothyroidism, sleep disorders, other systemic disorders like scleroderma, Peyronie's disease, prostate cancer treatment in the form of brachytherapy or prostatectomy can also produce erectile dysfunction. We have to keep one more factor that prolongs bicycling, that or any other activity that places the prolonged pressure over the pudendal and cavernous nerves or compromises the inflow of blood into the cavernous artery can result in penile numbness and impotence. The third important factor for male sexual dysfunction is early ejaculations. PE can occur approximately 3 to 4% of the male population, although upon questionnaires 30% of the men in community survey reports PE. Approximately 30% of the men with PE have concurrent erectile dysfunction, which typically results in early ejaculation without having sufficient erection. Premature ejaculation is now defined as a male sexual dysfunction characterized by ejaculation that always or nearly always occurs prior to or within approximately 1 minute of vaginal penetration, either present from the first sexual experience or following a new bothersome change in ejaculatory latency. The ability to delay ejaculation on all or nearly all vaginal penetration and negative personal consequences such as distress, bother, frustration and or avoidance of sexual activity. Risk factors being that low serum concentration level, lower urinary symptoms, medications like alpha blocker, tamsulosin, silodosin, antidepressants medications, selective serotonin receptor inhibitors. These are the medications associated with low orgasm or ejaculation. Surgery for benign prostatic hyperplasia, bladder surgery, long-standing diabetic mellitus, these are also the causes. Delayed ejaculation is characterized by a repeated inability to reach orgasm or by a very delayed orgasm after normal sexual excitement. A leading psychological causes appears to be performance anxiety and the spectator role. Now, as an urologist, we all encounter BPH patients in our regular practice, and you all know that BPH and ED are very much found concurrently. The multinational survey of the aging male study, which was conducted over 10,000 of population, it was conducted in Western countries, where it was found that 90% of these age group patients 50 to 80 have a luteus problem. Of them, 83% are sexually active, and among them, about 50% of the patients have erectile dysfunction. So it is important to evaluate and treat erectile dysfunction in the patients of BPH and vice versa. Indian study also has been done, and they also found the same results. ED coexist in 50% of the patients with BPH. Now, in short, female sexual dysfunction, here I will not talk much about it. Female sexual dysfunction, again, disorder of desire and mainly the psychological issue. Apart from the psychological issue, here also a socio-cultural issue plays a role, and the main leading socio-cultural theory is the restrictive cultural messages. And disorder of the sexual pain, vaginismus, it is characterized by involuntary contraction of the muscles of the outer third of the vagina. Fewer than 1% of the all women are affected by this. And the main cognitive behavioral therapy behind vaginismus is the learned fear response. Some women experience painful intercourse because of infection or disease. Many women with vaginismus also have other sexual disorders. Disorders of sexual pain like dyspareunia. It is characterized by severe pain in the genitals during sexual activity. As many as 14% of the women and only 3% of the men suffer from this problem, usually due to prior injury, most commonly sustained in during childbirth. So with these messages, I will conclude my topic of the introduction to the subject. And now I will take this podium to introduce our invited speakers in front of you. Our invited speakers took all the pain to come from Delhi on our request. We are very much grateful to them. I would like to invite. I would like to introduce Professor Ajit Saxena. Sir is a senior consultant urologist and andrologist in the Delhi West. Sir has 35 years rich experience in the field of urology and andrology. He was a founder and former president of Andrology Society of India. He also holds the post of President Delhi Andrology Society. Sir is one of the pioneers of the teaching robotic prostate surgery in India. Dr. Ajit Saxena has been awarded with various awards, and he has also held very prestigious posts also. Sir was among the few awards. Sir was awarded by UP Ratna Award and Japanese OISC International Award for Surgical Excellence. It's my privilege to also welcome Sir on this occasion. I would also like to introduce Dr. Sanjay Garg. Sanjay Garg sir is a senior consultant urologist and andrologist in Manipal Hospital, formerly known as Columbia Asia Hospital, based in Ghaziabad. I will also like to invite Dr. Neeta Saxena. Madam is a senior gynecologist in Delhi. Madam Monica Agarwal is a senior gynecologist, Apollo Girdle Hospital, Mother and Child, Indrapuram, Ghaziabad. Madam will talk on female sexual dysfunction this evening. We all know that our next speakers are going to talk upon erectile dysfunction, premature ejaculations, and female sexual dysfunction. So without wasting further time, I would like to invite Professor Dr. Ajit Saxena to talk upon erectile dysfunction. We are very eager to listen from him what beyond PDE5 inhibitor and especially the surgical techniques for erectile dysfunction which we can adopt in our daily practices. So once again, I welcome all of you in this evening. You enjoy the evening and make most out of this. Thank you very much.